So I try to present as a case, and we're gonna use the working system that you try to many sessions today. So my case gonna cover the diagnosis and tuberculosis drug, and also the when to start ART, and also the drugs that can be used with rifampicin. So let's start with the case. So he is a 25 years old man. He is a driver working in Bangkok. He is a heterosexual. He also has multiple sex partner and regular condom use. He is also intravenous drug user and has tattoos. The first visit at Ramathibodi Hospital on the 29th of October. He presented with because he has a positive anti-HIV testing from drug addiction clinic outside my hospital. And at that time, he also had high-grade fever for 2 weeks and also had weight loss for 3 kilograms in 6 months, also cough for 1 month. The physical examination show the high-grade fever, also the oral candidiasis with enlarged axillary lymph node both sides, also the pleuritic papilla eruption. You can see on the right side is like 10 centimeters diameters of lymph nodes, and also the other one is 3 centimeters. So this is a basic laboratory investigation on the day that the first day that he came to the hospital. You can see he had a low hemoglobin of 9.5, and he doesn't have any co-infections. There's VDRL and also HIV antigen and anti-CV as well as serum crypto antigen also negative. But he has a little bit, he has high alkaline phosphatase and gamma GGT. The CD4 is only 49. The chest X-ray is quite normal. So I would like to ask you for, this is the first question, what should I do first? For lymph node aspirations, ultrasound abdomen, start ART, start cotrimoxazole for PCP prophylaxis, or start if you think about tuberculosis. So can we empirical for 4 drugs? So let's work. Okay, we can see both the voting score and the choice. So most of you do lymph node aspirations to see this tuberculosis or not. So we can send for acid-fast bacilli staining and culture. And some of you choose ultrasounds because he has an abnormal liver function test. And some of you start HS for TB treatment without doing any diagnosis. So in this case, we plan to do lymph node aspiration that you can see like the bedside diagnosis for tuberculosis, and we also we plan to do the ultrasound abdomen. This is the WHO guideline talking about caring for people who with advanced HIV disease. So when the patient visit at the clinic, so you have to take a history and also do the examination and also the screening for symptoms for tuberculosis, which is used, heard many times today. So if the TB symptoms present, so you can do the diagnosis either expert MTB if you have, or you can do urine lamp if you have, but we don't have, but some hospitals you don't have any of these investigations, or acid-fast bacilli staining, also the standards in some hospitals. So if the investigation positive for tuberculosis, so we start TB treatment right away. But if the investigation negative, so you can consider after diagnosis. But in sometimes we consider presumptive tuberculosis treatment in the patient who have seriously ill, or even if test is negative or result is unavailable. So the clinical manifestations of tuberculosis, it depends on CD4 cell count. So if the patient has a very low CD4 cell count, they usually come with extra pulmonary tuberculosis as well as disseminations. In severe immunocompromised settings, you can see the case with rapid progressions as well as sepsis syndrome. This is the table summarize the brief summarize of the clinical presentations of the patient who came with late HIV presentations. So tuberculin test usually is negative, and you can see adenopathy is quite common. For the pulmonary distribution from the chest X-ray, you usually see the lower and middle lobe, and cavitation is usually typical absence, and 50% of the case came with extra pulmonary manifestations of tuberculosis. So back to this case, 10 days later, he came to ER because of he has abdominal pain for a week. It's usually on the right lower quadrant pain all day. He still has fever, but no diarrhea and no nausea, vomiting. We did whole abdominal CT scan, and we see the multiple lymph node with MAT effect in the abdomen, usually cause mild right hydronephrosis, and also see the wall thickening of ileum and IC valve, hepatomegaly, and several tiny hypodensation in spleen, and also pericardial effusions for 2 centimeter thickness. So this is a CAT scan of the patient. You can see a very large hepatomegaly and splenomegaly, also the intra-abdominal lymph node here, and multiple lymph node here. So anyway, because the patient has scheduled to do the lymph node biopsy, and before the biopsy was performed, he came multiple times at ER because of abdominal pain, and he was received multiple doses of NSAIDs. Finally, the lymph node biopsy was performed on the 12th of November, and the finding of right axillary mass is about 13 centimeters with past 30 ml. And he also received multiple doses of NSAIDs for release the symptom of abdominal pain. On 21st of November, which is about almost 1 month after the first visit at my hospital, so the clinical progress, and he came to the hospital with the drowsiness, myopia, conjunctiva, and icteric sclera. You can see the hemoglobin decreased from 9.5 to 6.9, and the creatinine up to 4.3 because of multiple doses of NSAIDs to relieve the symptoms of abdominal pain. And you can see the liver functions got worse. He got the total bilirubin of 5 and increase of alkaline phosphatase and GGT. On that day, the lymph node pathology reported acute necrotizing inflammations, and this is pus from the lymph node. We did the acid-fast bacilli, and this is a modified acid-fast bacilli. You can see multiple beaded-like organism in red color on the blue background. This is positive for acid-fast bacilli, and this is from the past knot culture. You can see there's a lot of organism. And we did the PCR for tuberculosis, is confirmed positive, and no INH and no rifampicin resistant. We also do sputum ASB, it turned out to be negative. So for the diagnosis of tuberculosis, the initial diagnosis testing should be directed at the anatomical site. So in this case, he has a lymph node, so we should attack the node, and we send for histopathology, smear for acid-fast bacilli, and culture to confirm. And we did chest X-ray for every case, and if possible, we should do the sputum smear and culture. In some cases, we can do blood culture for mycobacteria, and we have a new testing that you can have a lecture this morning about the expert MTB, and also urine lamp, also the immune-based testing. For drug-resistant testing, in Thailand, we can do both conventional method or nucleic acid testing. So in this case, probably the diagnosis is disseminated tuberculosis with multiple lymph node, liver, spleen, and pericardium. So this is a baseline lab. You can see that he also has creatinine, acute kidney injury from NSAIDs, and also abnormal liver functions. So I would like to ask you which anti-tuberculosis regime that you need to give in this patient. Please vote. So you need like standard HRZ-CE, or you need to cut something out because of the renal functions and abnormal liver functions. So most of you still use all 4 drugs, INH, rifampicin, pyrazinamide, and ethambutol. Some of you may be afraid of rifampicin because of the patient have jaundice, or some of you choice D, which we put streptomycin. It's gonna be maybe contraindicated in this case because the patient have a high creatinine. So in this case, we think that the abnormal liver function here is because of the patient have disseminated tuberculosis. So in this case, we try to put all 4 drugs, including rifampicin, because rifampicin is the most important anti-tuberculosis for the patient. So if you think that this liver function is not from other cause and from TB itself, we should use all 4 drugs together and close follow up the liver functions of the patients. And in this case, you have to adjust the dose of pyrazinamide and ethambutol, which is the 2 drugs that you need to adjust according to creatinine clearance. But for INH and rifam, you don't need to adjust for creatinine clearance. For the regimen and duration of tuberculosis, there is nothing new. Right now, we still use the standard regimen for HIV and TB co-infection. So we go with 2 months of INH, rifampicin or rifabutin, and pyrazinamide and ethambutol. If you send for the culture, it is come back that ethambutol is sensitive. If the culture, the tuberculosis is sensitive for INH and rifampicin, you can discontinue ethambutol. And then we add another 4 months of INH and rifampicin for uncomplicated tuberculosis. And we still encourage to use daily therapy, maybe range from 5 to 7 days per week with dots is recommended. So this is just briefly the doses regimen for the anti-tuberculosis. We need exactly calculations the doses of pyrazinamide and ethambutol according to this table. So the next question is when to start ART in these patients. So I would like to show you the lesions of the axilla. This is 2 weeks after we did the aspiration and incision and drainage. So it's quite normal right now. So I'd like to ask you that when to start ART in these cases. Please vote. So you will wait just only for 2 weeks, 4 weeks, 8 weeks, or wait until liver function normal, or until renal functions is normal. Okay, so most of you think that we should start early because in this case he has very low CD4, just only 49. And some of you may wait for 4 weeks and 8 weeks. So in this case, we start at 2 weeks. We didn't want to wait until the liver function normal and the renal function is normal. So the problems when you start ART with anti-tuberculosis drugs. So many of you know that we have the toxicity which is quite the same, drug-drug interactions, high pill burden, and also AI risk issue. So some of you may have the patient with a pathological iris, which is when you have a opportunistic infections diagnosed and treatment, and then the patient improve, and then you start ART, and the patient clinical presentation is deterioration again. So in this setting, it is typical that we call paradoxical iris, but you have to differentiate it from other causes such as ART or OI treatment toxicity, OI drug resistance, poor adherence of the patients, and also other OIs, but not the same OI that the patient has. This is a brief summary of the knowledge of paradoxical TB-associated iris. So the incidence overall is around almost 20%, but it can range from 4% to up to more than 50% in some studies. They have a study in children, a prospective study, show that the incidence is around 6.7. The risk factor, as you know, that very low CD4 cell count at ART initiation, high HIV viral load, and shorter time between TB treatment and ART initiation, and also disseminated tuberculosis and high mycobacterium load. So the clinical presentation may be as systemic presentation, pulmonary or lymph node presentation is the most common. The median days to symptom onset report around 6 days, but it can range from 1 day to around 3 weeks. And the all-cause mortality about 7%, but the iris associated death is only 2%. And we can see the higher mortality in the patient who have CNS TB iris. For pathogenesis, we think that it should be about the immune activation and also cytokine mediations. The treatment right now is a prednisolone. This is a regimen, and we try to not to stop ART, and we need to investigate for other cause and provide a symptomatic treatment. There's another term of iris that we call unmasking iris. This is the opportunity infections that we can diagnose after the patient initiations of ART. But in this case, you have to, sometimes you need to differentiate it from other conditions such as we miss OI diagnosis at the presentations, or the patient can have new OI due to the persistence of immune deficiency, but not unmasking iris. So this is the summaries of the recommendation for when to start ART after initiation of TB treatment. I try to list from the many guidelines. This is a DHS guideline, AAS, European, WHO, and Thai guideline. And you can see that if the patient have low CD4 cell count less than 50, all of guidelines say that we should start ART as soon as possible, and usually within 2 weeks. In Thailand, we put 4 weeks because sometimes we cannot, it's impossible to start within 2 weeks. For the patient who has higher CD4, let's say more than 50, most of the guidelines say within 8 weeks. And for European guideline, they say that we can wait until 12 weeks, especially in the case of difficult drug-drug interactions, adherence issue, and also toxicity. I would like to show you another case of the iris, but not in this case. So this is a man who developed fever, weight loss, and light axillary mass for a month. The CD4 is only 23, and the pus here positive for acid fast. So then I start the 4 drugs for tuberculosis. So 4 weeks after start TB treatment, the lesion is very good. So I start antiretroviral drugs. But after 2 weeks, he developed another mass at right next, and we can isolate as pus here. But we send everything is negative. We negative for acid fast bacilli and negative for bacterium culture. So this case, this is another kind of pathological reaction or iris. For the treatment of iris, we call it triple S. So you need a symptomatic treatment, supportive treatment, and surgical or percutaneous intervention in some cases. Penicillin still the standard of treatment for if you think that you want to give for symptomatic treatment for iris. They have a paper about NSAIDs in some cases, and another two, this is just a case report about thalidomide and montelukast for the treatment of iris. And you may have heard about the prevention of iris this morning about this paper, so I will skip this one. So let's back to the question about which ART that can be used with rifampin. So please vote for this case. Oh, sorry. Okay, anyway. I think you can vote efavirenz, right? So you know that this is a table summarize drug documentation with rifampicin. So for PI, we should avoid for all class. For NRTI, they have a data about efavirenz and nevirapine if you want to use nevirapine. And for etraveline and rilpivirine, we should avoid it. For integrase inhibitor, the data show that you can use raltegravir and dolutegravir. And for TAFs, you can see that right now we have to wait more data. This is a brief. You see all this slide this morning because this is the data about raltegravir and rifampicin that we can use. For Thai guideline, we recommend that you can use the usual dose for 400 milligram BID, but in some guidelines that you can see, like DHS guidelines, you can see that the recommendation is up a double dose of rifampicin. So the inspiring study, you have heard that dolutegravir can be used with rifampicin, but we have to double dose to 50 milligram BID. And this is summaries of the many guidelines that I try to put all in one table. So this is IS, European, WHO, and Thai. So you can see that all of these guidelines put efavirenz for the first line treatment with rifampicin. And for DHS guideline and AS, they put raltegravir with double dose and dolutegravir with double dose when using with rifampicin. For European, they put dolutegravir as alternative. WHO, they put only efavirenz and nevirapine in the guideline for 2016. In Thailand, we put all drugs that can use together with rifampicin, but we put efavirenz first. And if you want to use nevirapine, not lead in, we put raltegravir with normal dose, so 400 BID, and we put dolutegravir 50 milligram BID. So all these four drugs that you can use with rifampicin. For TAF, you have heard that we need more data. Even TAF, because of this is the data in healthy volunteer. When you use TAF with rifampicin, you can see that the level is decreased by half when compared to TAF alone. But even the TAF plus rifampicin, the level is decreased, but it's still higher than TDF alone. So right now we need more data that TAF can be used with rifampicin or not. If it can use, it should be which dose, the normal dose or double dose for TAF. So we need more data of TAF and using with rifampicin. For bictegravir double dose, the result, if you have heard this morning, that this combination is not recommended, so we cannot use bictegravir with rifampicin. So in conclusion of my case, tuberculosis diagnosis is still based on history, physical examination, and laboratory investigation. So if you don't have gen expert, you don't have LAMP, so we still use acid-fast bacilli, we can use culture. So for anti-tuberculosis, we still use the standard drug, which is INS, rifampicin, paracetamide, and ethambutol. For in this case, we have the patient have acute renal failure, so we need to adjust two drugs. So which is paracetamide and ethambutol. When to start ART, all the guidelines here say that we should start as soon as possible and within 2 weeks after ART initiation, especially when the patient had CD4 less than 50. For iris issue, we need to monitoring, and penicillin still the standard for treatment if you want to treat a patient who has iris. For anti-antiviral drugs that can be used with rifampin, so efavirenz still the first recommendation, and also two integrase inhibitor, which is raltegravir and dolutegravir, that can be used with rifampin. So I would like to finish my cases. Thank you for your attention.
Thank you very much, Professor Sasisopin. And then we have ample time this afternoon, so if anybody in the audience has any questions about cases at home or things you are interested in, please come forward, state your name. Any questions from the audience? Not yet. I have one question. Oh, I have two questions actually, Achan. You said that the starting within 2 weeks in Thailand is sometimes not feasible. I was wondering, like, what are the obstacles, and is there something that you think could be done, as it's probably applicable to countries in the region as well?
Yeah, I think because of the patient in Thailand, they have very sick, and most of them have an extra pulmonary or disseminated tuberculosis. So after you treat just only 2 weeks, most of the patients still look sick, and they're not ready to start antiretroviral therapy. This is one issue. And the other thing is that when we start tuberculosis, and sometimes we would like to see the patient or appoint back at 2 weeks at the clinic. But in Thailand, the patient may live far away, so they cannot come back within 2 weeks. So they need like 3 or 4 weeks to, if the patient not stay in Bangkok, outside Bangkok, and they need like 2 weeks is too short to them to come back to the OPD.
Okay, so also clinical reasoning, very good. And then the other question I had was, you showed us that in Thailand you do not recommend raltegravir at double dose. Yes. When treating. Do we have PK data to support that, and is that also something our neighboring countries could use? Is it body weight related? What's the reasoning? Yeah, because of the reflex study, you can see from the study, I would like to show you. So from the reflex study, that they divide the patient into 3 groups. The first group used efavirenz here, and the second group used raltegravir BID, and the third group used raltegravir double dose. So you see that the treatment outcome of HIV, this is a HIV viral load less than 50. You can see the 3 groups is not significant difference. So that's why we think that raltegravir 400 BID is not far different from raltegravir double dose, and because of the cost issue as well, because your double dose is quite expensive in Thailand. So we recommend the usual dose for with rifampicin from the reflex study. Very, very useful in the context of NNRTI resistance. Okay, thank you very much. Any questions? If not, then I would like to thank you very much. Okay, thank you very much.